Hello, future nurses. Today we are going to be talking about heart failure. So this first slide here just comes from the Khan Academy on YouTube, and it just kind of goes through what is heart failure. You can also find this video on Momentum. Okay. So heart failure. With heart failure, it's basically the inability of the heart to maintain adequate cardiac output to meet metabolic demands of the body due to that impaired pumping ability. So like I talked about before, most of our cardiac problems come back with this poor perfusion. We don't really do anything until we see poor perfusion. So with this heart failure, we've got it where it's not putting out enough output to actually give the body what it needs. What happens is you'll have a weakened ventricle muscle. So they're unable to sufficiently pump blood into the arterial circulation to meet the needs of the tissue. So it is one of the most common causes of hospitalizations, but the good thing is patients are living longer with heart failure due to these improved treatment options we have. So we've got different risk factors for it. Two of the bigger risk factors are hypertension, which is the greatest risk factor, and myocardial infarction or a heart attack. So with hypertension, more than 75% of patients have hypertension prior to being diagnosed with heart failure. So what's happening with this hypertension is you've got that increased pressure. So the heart is chronically working hard to push against it. So then we get those weakened ventricles. And then eventually this leads into that poor perfusion, poor cardiac output. Then you've got your myocardial infarction, which is your heart attack. About 22% of men and 46% of women will develop heart failure within 6 months following an acute myocardial infarction. This is why, like when we talk about our myocardial infarctions, next lecture, we kind of talk about different things that we do post MIs. What happens is you'll have a clot, which causes diminished blood flow to the heart tissues, which causes ischemia and infarctions of the heart tissue and heart failure. Once again, it all comes back to how are my ventricles doing? This is just the blood flow through the heart. You can see the right versus the left side. I always say kind of know how the blood flows to the heart because it makes it easier both when you're trying to study valve disorders as well as when you are studying heart failure. Because remember, the right side of the heart pulls blood back into the heart while the left side of the heart is pushing it out. So you'll usually see left ventricular heart failure first before you see right, unless you have a pulmonary issue. This is just some general terminology. Cardiac output is hopefully it's refresher, but cardiac output is the amount of blood that the heart pumps out of the left ventricle each minute. So that's why we talked about this in reference to cardiac output. It's diminished in heart failure because the left ventricle is weakened and cannot adequately pump blood out of the chamber. So you have that low cardiac output. Cardiac contractility is the ability of the myocardium to stretch and contract in response to the filling of the heart with blood. So some of our medications will affect this contractility, and we'll talk about that when we get to those meds. Stroke volume is the amount of blood within the ventricle that is ejected with each contraction. This is also referred to as that left ventricular ejection fraction. So you can see it as that EF or stroke volume. So our left ventricular ejection fraction, this is the volume of blood pumped with each ventricular contraction. In healthy individuals, approximately 55 to 70% of the blood in the left ventricle is pumped out with each contraction. A left ventricular ejection fraction of lower than 40% is indicative of heart failure. So kind of knowing that means that it's going lower there. So there's 4 different pathological causes of heart failure. And a lot of times these are initiated by a precipitating event. So it can be increased volume or volume overload, impaired ventricular filling, degeneration of ventricular muscles, decreased ventricular contractility function. So you can kind of like go back and think about things that you learned in Med-Surg 1, or even things that you learned in fundamentals about what can cause these fluid overloads, what's causing that impaired ventricular filling, what's causing that degeneration of ventricular muscles or decreased ventricular contractility function. If you think about it, that's why hypertension a lot of times will lead into that heart failure, is because we're putting so much strain on having to push out more blood volume. And any of these can lead to that reduction in cardiac output and cause those compensating mechanisms that are associated with heart failure. So these are just some of the major causes of heart failure. Repeated ischemic episodes of the heart, also called ischemic cardiomyopathy, myocardial infarction, chronic hypertension, chronic obstructive pulmonary disease, COPD, which leads into that right ventricular failure, dysrhythmias, valve disorders, so mitral insufficiency, aortic stenosis, and pulmonary embolism, which also leads to that right ventricular failure. So with your chronic hypertension and heart failure, high aortic pressure against the left ventricle, which causes that left ventricular hypertrophic to occur, which is unable to pump out the blood significantly, which leads to heart failure. So like I said, it causes this pressure here to push against this left ventricle. So since this is a muscle, this muscle is becoming bigger. So it becomes hypertrophic. And when it becomes hypertrophic, it's not able to pump out blood the way it should. And when it's not able to pump out blood the way it should, we're seeing those manifestations of heart failure. Coronary artery blood flow becomes insufficient to supply the enlarged left ventricle, ischemia of the left ventricle after an MI, heart failure. So in both these situations, it just all comes back to I'm having to put more resistance in this area. I'm having a harder time pumping blood out. So this muscle develops, and now as a precursor after this has happened, it's much harder to pump out blood. Here are some more major risk factors. And that last picture was just so you could see it a little bit easier. Here are some more risk factors for heart failure. Age, heart failure risks increase with advancing age. It's the most common reason for hospitalization in people age 65 and older. Ethnicity, African Americans are at a higher risk. Family history and genetics, diabetes, ischemic heart disease, obesity, hypertension. So lifestyle factors, things like smoking, like staying stationary, not moving around much. So we've got different types of classification. You've got your right-sided versus your left-sided, and systolic dysfunction versus diastolic dysfunction. With your systolic heart failure, the weakened ventricle has difficulty ejecting out of the chamber, inadequate ventricular emptying happenings, diminished stroke volume and cardiac output, blood accumulates in the ventricle, backs up into the atrium. So it's like where we're having an issue actually pushing the blood out. Diastolic, the ventricle has difficulty relaxing. So with systolic, it's I've got that difficulty pushing. With diastolic, it's I have a difficulty relaxing. It's less elastic and cannot expand fully. The stiff ventricle cannot fill with blood adequately, pumps out insufficient blood volume, diminished stroke volume, and cardiac output. So I like this picture because it kind of gives what I'm talking about here. So in a normal situation, ventricles fill normally with blood. So you've got that left ventricle here, filling fine. Systolic dysfunction, weakened distended left ventricle cannot pump blood forward. So it's just kind of weak. So it's actually the push. This right here where it's trying to push isn't actually going the way it should. Diastolic dysfunction, stiff, non-elastic left ventricle with less filling of blood. So we're just not completely filling this portion up here. While systolic, it's a matter of I can't push outwards. Diastolic, it's a matter of I can't actually fill up with enough blood to push outwards. So with the left ventricular failure, The backward effect causes a buildup of pressure in the left atrium, pulmonary veins, and pulmonary capillaries. This all causes an increased hydrostatic pressure in the pulmonary vasculature. Fluid is pushed into the pulmonary interstitial and intercellular spaces, which causes pulmonary edema or pulmonary effusion. So that's where you get those symptoms of crackles, cough, dyspnea, orthopnea, pink and frothy sputum, which means very severe pulmonary edema. The forward effect, decreased perfusion of the brain, kidneys, and other organs. So as you can see here, in that left ventricular failure, it's too weak to kind of push back. So then you're getting that buildup of pressure back into the left atrium and back into the pulmonary veins, pulmonary capillaries, and basically it's all kind of coming in here into the actual lungs. So that's why we're seeing the symptoms. So this right here is all just your kind of pathophysiology of it, of what's going on, why we see the symptoms we see. This is just kind of like a refresher of hydrostatic pressure and osmotic pressure, just so that way you know what I'm talking about. So hydrostatic pressure is just that force that attempts to push fluid out of the capillary pores and into the interstitial and intercellular spaces. Osmotic pressure is the force that attempts to pull fluid from the interstitial and intercellular spaces into the capillaries. Particles within the blood, such as albumin, sodium, glucose, exert osmotic pressure. Both osmotic and hydrostatic pressure forces oppose each other at every capillary membrane to attempt balancing each other. So this is just how it normally works, is basically you've got osmotic and hydrostatic pressure that are kind of keeping the fluid where it needs to be. But in this situation, that increased hydrostatic pressure, because it's not pushing out the way it should, is causing it all to kind of backflow into the lungs. And this right here is just like our pulmonary edema and pleural effusion. So when you start seeing that pink frothy sputum, that's when we're getting very concerned that we're filling with something like where we're getting this edema. If you look at this pleural effusion, that's going to cause a compressed lung. So they're not going to be able to fully expand the way they should. So one of the things you might see is your orthopnea. So lying flat, the patient has the most difficulty breathing because fluid transfers throughout the lung tissue. Semi-Fuller's position causes fluid in the lungs to move down toward the bases. Seated position, also called high Fowler's position, gives the greatest relief in orthopnea. So this is the justification for why we sit patients the way we do, is it's kind of actually pushing some of this fluid down so they can actually expand and get that breathing going. So this is some of the forward effects in left ventricular failure. Inadequate ejection of the blood into the aorta causes diminished perfusion throughout the whole arterial circulatory system. So we've got decreased systematic arterial pressure, as you can see it on here. That weakened left ventricle cannot adequately pump blood forward into the aorta. Blood flows into the aorta is decreased. Decreased perfusion of vital tissues. So now you're going to have a stimulation of the RAS, ADH, and sympathetic nervous system. So with your RAS system, and I've got a picture on the next slide too. We've got renin, angiotensin, angiotensin 1, angiotensin 2, peripheral vasoconstriction and stimulation of the adrenal glands, aldosterone, sodium and water reabsorbed, increased blood volume and blood pressure. So what's happening with this failure is because we're not pushing out enough blood to our body thinks we don't have enough blood available. So all these systems are basically going to fire off and tell us to hold on to fluid. So this is why in really bad heart failure, we start telling the patients to restrict their fluid, is because we're holding on to way too much fluid. So yes, like I said, with this, we're causing that cycling RAS and left ventricular failure. So what's happening is it's not getting as much blood pushed outwards. So now we're causing our vasoconstriction of our arteries. With right ventricular failure, backward effects are most apparent on physical examination. So with our Left ventricular failure, we're seeing more forward effects, while in our right, we're seeing more backward effects. So pressure increases in the right ventricle, right atrium, inferior vena cava, and superior vena cava, jugular venous distension, ascites, hepatic venous congestion, hepatomegaly, splenic venous congestion, splenomegaly, ankle or sacral edema. So on this one, instead of it being a push, we're seeing a pull backwards. So it's a much more difficult backward effects with it. So core pulmonale right ventricular failure is caused by your lung disease. So what happens is step one, you'll have this chronic hypoxia develops due to lung disease. Step two, chronic hypoxia causes pulmonary arterial vasoconstriction called pulmonary hypertension. Pulmonary hypertension causes high resistance against the right ventricle, eventually weakens, and right ventricular failure occurs. So when it comes to lung issues, you'll see more of the right problem than you'll see with the left problem, because it all comes back to that vasoconstriction and that pulmonary hypertension, where it's all doing that backflow. So our BNP in heart failure, as the ventricle stretches in response to increased blood volume, the myocardium secretes BNP. So that's a natural diuretic substance. Level of BNP greater than 500 are considered indicative of heart failure. Yes, so that's one of those tests that you can look at. Hypokalemia in heart failure. In heart failure, blood volume increases because of excessive water within the bloodstream. This dilutes the serum electrolytes, sodium and potassium, dilution, hyponatremia, and hypokalemia. So because we've got so much blood volume, it's causing all of our electrolytes to kind of be diluted. So you're going to see a hypokalemia. In addition, with the constant cycling of the RAS in heart failure, aldosterone causes potassium excretion from the kidneys, which causes that risk of hypokalemia. So what are our expected findings? That was all our pathophysiology. So what are we as the nurse going to see in these patients? Because I like to kind of explain what the patho is before we get into our symptoms. Because if you look at all these symptoms, it makes sense with everything we just discussed with our pathophysiology. So some of our expected findings with ventricular-sided heart failure. We've got dyspnea, orthopnea, that's that shortness of breath while lying down, nocturnal dyspnea, fatigue, displaced apical pulse, so that's due to that hypertrophic portion of the heart, S3 heart sound, pulmonary congestion, dyspnea, that hacking cough, you can hear crackles, frothy sputum can be blood-tinged. And if you remember that pink frothy sputum, that's when we start getting very concerned, because that's an indication of pulmonary edema, which we'll talk about more when we get into our respiratory lecture. Altered mental state, oliguria, nocturia. So just kind of thinking about these things. Whenever you see, think left for lungs. That's how I always remember, left for lungs. And it's that pushing outwards, and now it's pouring all kind of back into the lungs itself. So we're going to see respiratory problems. So when you see things like that hacking cough, if you see things like that pulmonary congestion, anything that has to do with the lungs, I'm thinking more of my left-sided heart failure. And I have this picture here for you guys, so you can kind of see it, because it's kind of helpful to look at that. So what are my expected findings for my right-sided heart failure? So my right ventricular failure. This one, remember, the right side of your heart pulls things back. So what you want to picture is a bunch of edema, peripheral edema, all this edema kind of swelling and kind of that fluid overload. So you're going to see things like jugular vein distension, peripheral edema, abdominal distension, so ascites, fatigue, weakness, nausea, anorexia, polyuria at rest, enlarged liver, and tenderness and weight gain. So once again, on this right side of the heart, we are lacking that pulling back. So we've got those increased fluid everywhere else in our peripheral tissues. So when you're assessing your patients, they're not going to go up to you and be like, I've got edema. You have to look for your subtle signs from your patient that can indicate things are getting worse. So when you hear things like complaints of tighter shoes, that may indicate increased edema. When you hear things like I'm having more trouble or I'm having trouble breathing when I climb up a flight of stairs, I'm thinking increased dyspnea. So you have to kind of listen to what your patients are saying, so that way you kind of understand their language, because we've got the language we use and then we've got the language that the patient uses. So these are just some lifestyle factors for increased edema. So what can cause them to have more edema on them? So these are things that when you talk to the patient, you want to kind of make sure that you add into your education. Things like sodium intake. If they've got increased of salty foods, so if they're eating a lot of McDonald's, a lot of putting salt on every meal, you may tell them, hey, maybe slow down a little bit on the sodium because that's going to cause ankle edema. That can cause this edema to get worse. Traveling. So a lot of times when you travel, that can also cause increased ankle edema. Medication compliance. So if they're not taking the diuretics, that can cause it. Increased fluid consumption. So if they're drinking a lot more fluids, and alcohol intake. So our treatment for heart failure, you want lifestyle modifications first. So things like low-fat diet, non-smoking, low salt, walking, physical activity, low alcohol use, weight loss if obese, annual fluid vaccine, pneumococcal vaccine every 5 to 10 years, and daily weight measurement. Now, this low-fat diet isn't going to affect the heart failure necessarily. It's not going to really affect the heart muscles, but it will allow them to not have as much weight on them. The one that's going to affect fluid would be that low salt, because that's the sodium with it. These are just some of the medications, and we're going to go through quite a bit of medications in the next couple slides. So the first one is our diuretics, which cause preload reduction. So the reason we give diuretics is to decrease preload. We don't want as much fluid kind of going in. So you can have things like your thiazine diuretics, your loop diuretics, potassium sparing diuretics. If taking a loop or a thiazine, ingest foods and drinks that are high in potassium. If taking potassium sparing diuretics, watch out for your hidden sources of potassium, such as your salt substitutes. So just make sure that they're watching those salt substitutes. Afterload reducing agents help the heart pump more easily by altering the resistance to the contraction, counterindicated for patients who do have renal deficiencies. So these are things like our ACE inhibitors, our angiotensin receptor 2 blockers, our calcium channel blockers, and things like our phosphodiesterase 3 inhibitors, so our milorone, which we'll talk about. So our ACE inhibitors. So you want to monitor for patients following initial dose, mostly because right after they take it, you just want to look to make sure that they're not having hypotension. These end in Pearl. So anytime you see a medication that ends in Pearl, that is an ACE inhibitor. The way I always remember it is Ace Ventura was born in April and he has heart problems. So it's an ACE inhibitor. It can cause angioedema, so swelling of the tongue and throat, decreased sense of taste, or skin rash. You want to watch for increased levels of potassium, your hyperkalemia. So like I said before, you want to look for those hidden potassiums, your salt substitutes. Encourage the patient to ask for assistance, especially when you give them that very first dose of the medicine. You want them to wait before they get up. Because like I said, the initial dose can cause hypotension and everybody works a little bit differently. So that first dose, you just want to let them know, hey, before you get up, you want to either be with me or be with the UAP or whatever your facility calls the nurse's aide. Inotropic agents are used to increase contractility and thereby improve cardiac output. So it improves that blood pressure. So things like your milorone are one of these, and it's all about kind of helping those contractions to improve that blood pressure. So digoxin, dopamine, dobutamine, milorone are usually your main ones. Digoxin, always observe for that toxicity. So I'm looking for that nausea. I'm looking for that yellowed vision. And remembering that if you give dopamine, dobutamine, or Millerone IV, these are those central line medications. So if all of a sudden you get a dopamine infusion, remember, hey, I need to go get a central line supply for this, because more than likely we're going to have to put central line in this patient. They're very toxic drugs to the skin. Beta blockers used to control heart rate. These usually end in your LOL or ILOL. So, it's funny to be on a beta blocker. Monitor blood pressure, monitor your pulse. Don't administer for bradyrhythms. So if you've got a patient who's on a beta blocker and their blood pressure, or sorry, their heart rate is less than 60, you want to clarify before you give it. You want to make sure that you're talking to the healthcare provider and seeing that they're okay if they're at one of those lower levels that's lower than 60. You want to check your orthostatic blood pressure readings as well. Our vasodilators, we're probably going to talk about a little bit more during our emergency lecture, just because those are things like our nitroglycerin and our isosorpin. So these prevent coronary artery vasospasms and reduce preload, afterload, decreasing myocardial oxygen demand. They're usually given to treat angina and help control blood pressure. You want to use cautiously with other antihypertensives. A headache is common, and change your position slowly. So with our nursing care, because we learned all the meds, now it's on to our nursing care. You want to monitor daily weights in eyes and nose, assess for shortness of breath and dyspnea on exertion. So dyspnea on exertion, like I said, when we're assessing for that, we're looking for the patient's description of that. So that's like, I'm finding it difficult to walk upstairs, or it's hard for me to do daily activities. Administer oxygen as prescribed, monitor vital signs and hemodynamic pressures, high Fowlers, if they need it, assess for dish toxicity, monitor dietary restrictions, and provide emotional support to both the patient and the family. So our dietary restrictions. So a lot of these patients will be on fluid restrictions, but that does not mean that 100% of the patients are on fluid restrictions. So a lot of times what will start out is restricting sodium first. So it's a little bit easier sometimes to restrict the food than it is to restrict the fluid. So with that, you kind of want to decrease fluid retention by decreasing sodium. So for those early stages, it may only require dietary adjustments and not require fluid restrictions. So with that, teaching your patients no canned veggies and fresh or frozen vegetables are the best. And the reason we say that is because a lot of those canned veggies will have quite a bit of sodium in them. So you want to make sure that they're not doing any salty foods and that you're watching for hidden signs of sodium. But like I said, it all comes back to low sodium diet means decreased fluid retention. So if we can get them to restrict their sodium, we may not have to necessarily restrict their fluid just yet, trying to keep them from going into full blown out heart failure. These are just some of our interventional cardio procedures. And this picture here shows an intra-aortic balloon pump. We have to go to the actual site for it. It should be on Momentum as well if you want to watch it. A lot of these we've kind of like talked about throughout our lectures. So with our complications, you can have acute pulmonary edema, which I've got on the next slide. Cardiogenic shock, which will cause that tachycardia and hypotension. Pericardial tamponade, which is the same thing as cardiac tamponade, which is that fluid accumulation in the pericardial sac. Your symptoms are things like your muffled heart sounds, sharp pain in the chest, trouble breathing, and your treatment is that pericardiocentesis, which, if the procedure is effective, what you should see is that rise in blood pressure. So hopefully once we get the fluid off, the heart starts pumping appropriately again, and I want to see a rise in blood pressure with them. And this here is just a picture of pulmonary edema. We've got cardiogenic edema, which is caused by heart disease, and then non-cardiogenic pulmonary edema, and the presence of damaged pulmonary capillaries. So you can kind of see here with that fluid buildup. And like I said, we'll see this again towards the end of the semester when we get into our respiratory chapter. As always, thank you.